Hello guys, let's start our class on cardiovascular physiology. And we will divide this class into two parts. First of all, we will today discuss some topics around the topic of cardiovascular physiology, and we will discuss the rest of the topics on 15th, I guess. So let's go. Our first topic is about the cell change that occurs during the cardiovascular contraction or cardiovascular regular physiology. So the cell change that occurs is due to the change of the charges in the cell membrane. The charges that occurs is due to the Nernst equation, basically, which causes change in permeability, electrical gradient, ion gradient, and charge of the ions that are known as the membrane potential. Membrane potential basically means that if there is two sides of the membrane, such as if this is the membrane, these are the two types of the membrane. Suppose here are one minus and there are three minuses. So the membrane potential will be minus three, minus one. So that will be minus two. Okay. So this is basically the um, membrane potential. So yeah, membrane potential is basically the difference between the two sides of the membrane's ion. Okay. Okay. Moving forward, if we move forward, and there will be membrane potential, electrical gradient, or electrical gradient. So, what is membrane potential? We have already discussed the membrane potential. What is resting membrane potential? Resting membrane potential is the membrane potential that usually stayed during the resting phase of that membrane. So yeah, and for different membranes that is present in our body, that is in different amount. Okay. Such as for nerve, the resting membrane potential is minus 70 millivolt. Then again, for sinoatrial node, the resting membrane potential is minus 60 millivolt. For skeletal muscle, that is minus 90 millivolt, and for ventricular myocyte, that is also minus 90 millivolt. And all these millivolts and all these numbers matters due to the action potential that occurs in any cell membrane or any cell that occurs through the depolarization and repolarization. And after the repolarization, when it keeps repolarizing, then the hyperpolarization occurs. So if the electrical potential goes towards the zero, that is called depolarization, and then it goes again the in minus direction, that is also called repolarization. And when it causes the repolarized resting membrane potential, then it goes down again and it causes hyperpolarization. Okay, so if you have to see this schematic diagram here, this arrow here in the upward portion of this schematic diagram. This arrow designates through the left hand side, which comes from the resting membrane potential, which is 70 millivolt, and it goes through the zero, goes towards the zero, and that is basically the depolarization. After the depolarization, there are basically uh, repolarization. Okay. Oh, pardon me for the interruption. Okay, so basically from minus 70 millivolt, the depolarized membrane goes through the zero, and then from zero, it repolarizes again towards the minus 70 millivolt or towards the resting membrane potential. And after repolarizing towards the resting membrane potential, it keeps repolarizing, and only then the hyperpolarization occurs. Okay, towards the resting membrane potential and lasting membrane potential, resting membrane potential. When it crosses the resting membrane potential, then it goes through the hyperpolarization. Okay? So repolarization from zero, it's going back towards the resting membrane potential. That's what we have been discussing for from this diagram. And repolarization towards the resting membrane potential, we know that hyperpolarization, when it goes beyond the resting membrane potential, that is known as hyperpolarization. Okay. And what are the channels that are present in our cell membrane? Okay, there are different channels that are present. There may be ungated channels, there may be voltage gated channels, there may be ligand gated channels. If the channel is basically ungated, that means there is nothing actually present for the transportation cause. So anything that goes through that cell membrane that can pass around. Okay, so they do not have any effect on the membrane potential. So goes through that anything that comes through that event that can go through. Okay, voltage gated voltage gated channel is, or voltage gland channel is, the change between the electrical gradient across the cell membrane will cause the passage of that particular particle through that cell membrane. Okay, and ligand gated channel is, a ligand is present in that particular receptor, and through that receptor the electrical change does not occur really, or basically change of the electrical gradient occurs, and this particle moves towards the electrical gradient. Okay, and in case of the voltage gated channel, the that particular particle that moves against the electrical gradient. Okay, so this is basically receptor based, but this is basically voltage based. Changes in membrane in case of potential, action potential occurs. Action potential is basically the rapid depolarization and repolarization of the membrane potential. Okay, so what we have learned through this is, when the depolarization occurs, when the repolarization occurs. What is depolarization? What is repolarization? What is ligand gated ion channel? What is ion gated channel? And what is ungated or leaky channels that is present? And we know during all this, the changes occur in our cell membrane, and which is the action potential that occurs in the cell membrane. In case of this action potential occurring into the cell membrane, there is influx of extracellular sodium and inside the cell, as extracellular sodium concentration is higher than the intracellular. So the influx of extracellular cell membranes from the cell, it goes outwards. 3 sodium goes outwards, and 2 potassium that comes inward into the cell. Okay, so as there is more extracellular sodium out there, it goes against the electrochemical gradient. So action potential occurs basically during that period. Okay, so it moves towards zero. So it's the depolarization phase of the action potential. Opening of the ligand gated ion channel, which basically stimulus has the reach to the significant threshold. Okay, this is basically resting membrane potential, and when the resting membrane potential is being reached, that particular voltage is being reached, then the action potential occurs, which is different for different ions as well. As we have already learned, this is different for the different nerve sheath or different cell membranes. In case of potassium, that is -95. In case of chloride, that is -76. In case of sodium, that is +70. In case of calcium, that is +125 millivolt. Okay, so depolarization of the ions are due to the opening of the sodium channel, and at a certain point the voltage gated sodium channel closes and opens. The opening of the closes and opening of the potassium channels occurs. Okay, so this is what we are studying here, is the basic cell membrane potential. So if we are to teach about the basic cell membrane potential, this is basically the basic cell membrane potential. Okay, so this is the depolarization, and this is the repolarization, and maybe hyperpolarization may occur as well. So this is the depolarization, where the sodium is present as well. So this is where the voltage-gated sodium channel occurs. Voltage-gated sodium channel gets open, and 3 sodium moves outwards into the, from the cell outwards into the outward, and then this is the repolarization, where the potassium moves into the cell. So 3 sodium moves outwards into the, from the cell, and 2 potassiums moves inward into the cell. Okay, 2 potassium moves inward into the cell. Mm, So this was basically our cell membrane potential, and during this salmon potential basically there is a certain point where the sodium channels get lost, which is the tip of that salmon potential, where the depolarization ends, then the repolarization begins. And during the beginning of the repolarization, the voltage gated sodium channels, the voltage gated potassium channels get open, and the efflux of the potassium occurs, where potassiums go out from the cell. And because of the increased concentration of potassium inside the cell, okay, so the sodium goes out of the cell and the potassium moves into the cell, as there is basically against the electrochemical gradient, and this will cause the repolarization coming back to the resting membrane potential. But the potassium doesn't shut quickly, causing the hyperpolarization due to the delayed closure of the potassium channel, as we have already discussed. Once the hyperpolarization has happened, there is change into the sodium and potassium ion. Okay, so sodium potassium ATPase acts and brings back the potential into the normal resting membrane potential. So when the hyperpolarization occurs, the voltage gated potassium channel does not close, and it is being closed, or it is being halted by the action of sodium potassium ATPase, which halts the hyperpolarization and moves the potential back to the zero or the resting membrane potential. That is basically stopping the resting membrane potential and setting the bar again for the depolarization and a new action potential. Okay, so uh, during this period, we will have to know about the all or none law, or all or none phenomenon. What is all or none phenomenon? It is basically the stimulation is if the stimulation is significant enough. If the stimulation is significant enough, the action potential will occur. But if the stimulation is not significant enough, the action potential will not work. Okay, if the action potential is will work when the action potential and the stimulus is significant. If the stimulation is significant enough, there will be action potential. If the stimulation is not significant enough, there will be not any action potential, and that is the uh, all or none phenomenon. Basically, three different stimulus from three different neurons or spatial simulation, and all of these are summated and then calls the single three differential stimulus, and which is known as the temporal summation. So temporal summation is important for our exams, but not that important. You should know about the concept, but yeah, I think we can move forward. So what is refractory period? Refractory period are being divided into two types of refractory period. One is absolute refractory period, and the other is the absolute and relative refractory period, right? So what is absolute refractory period? During the absolute refractory period, if you give the cell whatever amount of stimulus that you can, there will be no action potential, right? So during the absolute refractory period, the which has no matter how strong the stimulus is, it cannot induce a second action potential, mainly because the sodium channels are in open or inactivated states. Either the stimulus is, so voltage gated sodium channel is already open, or there is basically already open voltage gated sodium channel. So if the voltage gated sodium channel is already opened, or if there is not any scope of opening this voltage gated sodium channel right now again, there will be no depolarization. In that case, there will be no action potential. So that period of that action potential is known as absolute refractory period. But in case of a relative refractory period, there will be a certain amount of voltage present, and if you can cross that certain amount of volume, you can actually cause a second action potential. So that is why there is that amount of volume, or that amount of volume, or that amount of energy or stimulus is known as the relative refractory period. If you can cross that amount, there will be a second action potential. So stimulus has to be greater than the threshold. If the stimulus crosses the threshold, there will be a second action potential during the relative refractory period, but there will be no action potential or second action potential in case of absolute refractory period, however big the stimulus may be. Moving forward, we all know that all the action potential, or the conduction that moves through the nerve sheath, that goes through the myelin sheath. What happens if the myelin sheath is not working properly, and what are the diseases that may occur? In case of myelin sheath disorder, there may be Guillain-Barré syndrome and optic neuritis. We all know that Guillain-Barré syndrome is basically Campylobacter jejuni, when you are being infected by that specific organism, and after that 2 to 3 weeks later, and you develop ascending paralysis from your feet to upwards. This is basically known as ascending paralysis and Guillain-Barré syndrome. So basically this occurs due to the demyelination of the nerve fiber, and we've already basically got the ascending paralysis and demyelinating disorder. During optic neuritis, there will be monocular vision loss, which in case which the eye that is being infected or the eyes that is being affected is caused the optic neuritis, and there will be visual loss in that eye only, not the other eye. In multiple sclerosis, it may also occur, and demyelinating disorder, it is basically. There are basically two primary factors: the cell diameter and cell surface area. In case of more diameter, you can think it like as a big water pipe, right? So if there is a bigger pipe or bigger diameter of the pipe, a large number of water can pass through that pipe, but or tube, right? So, but if the diameter of the tube is smaller, smaller amount of water can pass through at the same time. So the cell diameter is important for the conduction velocity. So greater the diameter, the greater the conduction velocity. In But on the other hand, on the contrary, there is, if there is greater surface area, there is reduced internal electrical resistance, right? So if there is less or reduced internal electrical gradient, there will be more flow as well. Myelination, basically we all know that myelination occurs into the nerve fibers, and myelin basically provides greater electrical resistance across the cell membrane, and thereby reducing the central leak or current leak through the cell membrane. And the myelination is interrupted in the nodes of Ranvier, where the last sodium channel cluster, thus the action potential appears to bounce from node to node, that we all know, from the nodes of Ranviers one to another, and that is why the conduction is faster in case of myelinated nerve fiber than the non-myelinated nerve fiber. Okay, so this basically causes greater speed for the nerve conduction. Okay. Neuromuscular junction, we all know about the neuromuscular junction. If we had to draw a neuromuscular junction, I'm not really good at drawing, but let's draw this. Okay. Okay, so this is basically a neuromuscular junction. Let's just call it. This is a presynaptic cleft, and this is a postsynaptic cleft, right? So if we move forward, yeah, okay, you can see that if we move forward to here, the nerve impulses that enter the end of the neuron. So this is basically, we can imagine this as end of one neuron or exon of one neuron. So voltage gated potassium channel occurs in this part of this synaptic cleft or this part of the neuron, and voltage gated calcium channel causes influx of potassium inside the nerve ending. So here this there will be an opening of voltage gated calcium channel, and calcium will move inwards due to the calcium channel being open. So there will be a synaptic cleft vesicle burst open, and the neurotransmitter will comes out, right? So when there is influx of calcium, there the neurotransmitter vesicle will be called, and the vesicle will ultimately burst open, and the neurotransmitter will come out. The neurotransmitter get attached to the ligand gated channels, which is present in the postsynaptic cleft, right? So opening of the ligand gated channel in the postsynaptic cleft, and if the sodium channel opens, there will be excitatory impulse. So again, what happens is the nerve impulses that comes through from here, right? It comes through from here, and it causes the opening of the calcium channel in here. The calcium channel gets open, and it causes a synaptic cleft vesicle which burst open, and ultimately it causes the neurotransmitters are being released from here, and which neurotransmitter got attached to the postsynaptic cleft, and which causes the uh, opening of the sodium channel here. In case of this, the sodium channel gets open, and when the sodium channel gets open and sodium gets influx into the postsynaptic cleft, the action potential starts and the excitatory impulse starts, and the potassium channels open and the inhibitory impulse also starts, and this is called the end plate potential. Okay, so this is all about the neurotransmitter or the junction that is present in the neuromuscular junction. So basically the stimulation comes from the presynaptic cleft, which stimulates and opens the voltage gated calcium channel, which causes the influx of calcium inside the nerve ending, and the synaptic vesicle then bursts open and neurotransmitter comes out. That neurotransmitter gets attached to the ligand gated channel, and which causes opening of the channel. If when the sodium channel gets open, it causes excitatory impulse, and when the potassium channel gets open, it causes the inhibitory impulse, and this is called the end plate potential. Autonomic nervous system. Autonomic nervous system is very important for our exam, and you will have to memorize this chart as well. Okay, so target organ. If we are to see about the summary of this, you can see all through there is M3, 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 M3. Okay, M2 is basically present in the heart. Okay, heart basically consists of M2. Okay, SN node is basically M2, which causes decreasing of the heart rate and basically reduce chronotropic effect. And in case of the AV node, M2 is also works there, so conduction velocity is also less in case of autonomic nervous system or parasympathetic nervous system. Okay, so basically there is basically negative dromotropic effect. So in case of hearts, parasympathetic nervous system, the M2 receptor causes negative chronotropic and negative dromotropic effect. Okay. But in other cases, like in case of gland, there is M1, which causes increased secretion, and everything else like eye, GI tract, and GI tract, bladder, and blood vessels. Everywhere else, there is presence of uh, M3 receptors, which causes, in case of bladder, it causes a contraction of the detrusor muscle and relaxation of the sphincter, which ultimately causes urination. In case of blood vessel, the endothelium, there is presence of M3, and there is vasodilation that occurs due to it. In case of eye, there is presence of M3 receptor, which causes contraction and meiosis of that particular, due to the work of the parasympathetic nervous system into that particular receptor, which ultimately causes constriction and meiosis. So if we are to summarize this, if we all know that in case of glands, which are basically present in the GI tract, which causes increased secretion due to the effect of the parasympathetic nervous system through the M1 receptor. And in case of heart, there is presence of the M2 receptor in SN node and AV node. Both of them basically causes negative chronotropic and negative dromotropic effect in SN node and AV node. And everywhere else, there is basically presence of M3 receptor, which performs different function. In case of eye, there is contraction and meiosis. In case of lung, there will be contraction and bronchospasm, increased secretion as well. In case of GI muscles, there will be increased motility. In case of bladder, there will be detrusor muscle contraction and sphincter relaxation, and the blood vessels. In case of endothelium, there will be vasodilation present as well. So all the gland secretion due to parasympathetic nervous system, except for the sweat gland, in where sweat gland secretion actually works or actually gets increased due to the sympathetic nerves effect. Okay. So sympathetic nervous system, we have already from the autonomic nervous system, there are basically two parts: parasympathetic nervous system and sympathetic nervous system. In this box, we have already studied the parasympathetic nervous system. Moving forward, we will get to know about the sympathetic nervous system. When the sympathetic nervous system will get activated, in case of you are being chased by a dog, or you are in a very high tech or high adrenaline situation where you are into search of something, or you are being chased by someone, that will activate your sympathetic nervous system. So just like that, in eye, arteries and veins, there is presence of alpha 1 receptors. Basically in eyes, there will be due to the effect of the alpha 1 receptor, there will be dilation or mydriasis. In case of arteries, there will be the TPR will increase there, due to there will be total peripheral resistance will increase, that is basically increase, will increase the afterload. And in case of vein, there will be constriction of the vein as well, which is basically which will basically increase the venous return and ultimately will increase the preload. So due to the action of the alpha 1 receptor in the veins and arteries, there will be increase of preload and afterload. In case of bladder sphincter, the sphincter will be constricted, so there will be no urination from the bladders as well. And the detrusor muscle will also get relaxed, so that will also not aid into the contraction and urination as well. In case of SA node and AV node, we have already seen that due to the parasympathetic effect, there were negative chronotropic and negative dromotrophic effect. But now, as we are seeing the sympathetic effect into the SA node, AV node, Parkinson fiber, there will be increase or positive chronotropic, positive dromotrophic effect due through the beta 1 receptor. The beta 1 is also present in the atrial, kidney, and Parkinson fiber as well. And the beta 1 receptor in Parkinson fiber will increase the automaticity and conduction velocity of the heart. And in case of atrial, there will be increased force of contraction, and will from the kidneys there will be increased renin secretion. In the blood vessels, beta 2 receptors are present in two lungs as well. So all the blood vessels with beta 2 receptor will cause vasodilation, and bronchioles will cause dilation as well. Bronchodilation will also occur due to the presence of the beta 2 receptor as well. For non-epinephrine, there is no basically beta 2 receptor as in the is present. So that is why vasodilation basically occurs to the beta 2 receptors. Okay. Total peripheral resistance that decreases and causes decreased afterload, just as the alpha 1 basically cause the increased total peripheral resistance and increase afterload. So by reversing that physiology is reversed by the beta 2 receptor, where vasodilation occurs and afterload basically decreased. Okay. Electrical activity or ion potential is being produced by the delayed function of the seconds, and the hearts has electrical activity going this way. And this is why whenever we get electrocuted the patient, we should obviously do ECG, which alters the heart's function and the heart's electrical gradient, and which will also alter the electronics that passes through an electrical stimulus that occurs through the electrical stimulus that basically occurs through the action membrane potential. And that is why we will have to see, or we'll have to go through an ECG during when we are doing or we are assessing a patient who is being electrocuted through various process as well. So factors that is affects the pacemaker, basically chronotropic effect. In case of positive chronotropic effect, which will cause basically by the sympathetic activity or beta 1. But in case of M2 receptor or sympathetic parasympathetic activity, there will be negative chronotropic effect. Okay. And in case of conduction velocity, or the factors that affect conduction is basically dromotropic activity, and factors that affects the force of contraction is basically inotropic activity. So when factors that affects the pacemakers such as SA node and AV node is basically chronotropic potential. The factors that affects the conduction, that is basically dromotropic activity, and factors that affects the contraction or force of contraction is basically inotropes or inotropic activity. What is sinoatrial node? Sinoatrial node is basically the main pacemaker of our heart. So when the vagus nerve is being stimulated, there will be less heart rate, or chronotropic effect will be basically sympathetic, parasympathetic action will be there, so there will be less heart rate. And in treatment of the supraventricular tachycardia, we basically at first, if the patient is stable, we basically push the patient for the vagal maneuver, so that the heart rate is being decreased and the vagal tone is being increased. Okay. Located in the junction of the superior vena cava and the right atrium, the SA node or sinoatrial node is basically present in the located in the junction of the superior vena cava and the right atrium, where the uh, superior vena cava basically goes upward like this. Okay. So this is basically we can see this is superior vena cava, and this is inferior vena cava basically, and this is superior vena cava. Okay. And this is basically the right atrial wall, suppose. Okay. Uh, if we had to learn about a schematic diagram, there are many things. So basically, this is the inferior vena cava, and this is the superior vena cava. From both ends, there are bloods coming up, into the heart. Okay, this is the right atrium. Okay, this is the right atrium. Okay, this is the right atrium. This is the right atrium. Okay. Okay, so this is the right atrium. So it is the sinoatrial node or SA node that is present into the junction of the superior vena cava and the right atrium. So basically, it is present in there. This is the location of the sinoatrial node or SA node. This is innervated by both sympathetic and parasympathetic. We have already studied the effects of sympathetic and parasympathetic activity into the SA node of heart, or the so there is innervated by both sympathetic and parasympathetic or vagus nerve fibers as well. Parasympathetic by basically reduces the heart rate, and the sympathetic fiber basically increases the heart rate, which is basically a positive chronotropic effect. And specialized myocytes are also present, which also causes the different activity of the heart and the sympathetic activity from the heart as well. Special myocytes are incitation of the action potential pacemaker that is being generated by the impulse, generates the impulse and slightly faster than the others as well. That is why this is the main pacemaker of human heart. So SNOD is basically located in the SVC, superior vena cava, and the junction of superior vena cava and the right atrium. The right atrium of the heart is in the inferior wall. Basically, inferior wall of the right atrium of the heart is in the inferior wall of the heart, which basically dictates the 2-3 AVF leads of the ECG as well. So if there is any infarction in the inferior wall, the SA node can get involved or can get infected, which causes the fall of heart rate and basically indicates the heart block or heart failure as well. So inferior wall infarction, in case of inferior wall infarction, most common complication is bradycardia and heart block, which is basically caused by the right side of the right sided heart or the right heart as well, which is involvement of the SA node. So when there will be any changes in the 2, 3 and AVF node in our ECG, we will obviously have to look for the bradycardia or heart block as well, and we will know that this will be due to the involvement of the sinoatrial node. Okay, so in case of, we have already studied about the sinoatrial node, and now we are moving forward to the atrioventricular node. Okay, atrioventricular node lies in the atrial septum, just above the coronary sinus opening. Okay, just above the coronary sinus opening. Coronary sinus is basically the opening of the veins of the heart. Veins of the heart are basically opens into the coronary sinus, and which basically opens into the right atrium eventually, and that delays the function of atrioventricular node or AV node is basically to delay the received impulse. Delay the received impulse that is already being present due to the presence of the SA node from the, which is being generated by the SA node and which comes through the AV node and which being delayed by the AV. So AV node is being the impulse that comes from the SA node to the AV node is being delayed by the AV node, and this is approximately 120 milliseconds delay that provides two main functions. One, the atria contracts before the ventricle, and the protection from the excessively fast ventricular response to atrial arrhythmias. Decremental conduction, more frequently the nodes that is stimulated by the slower it conducts. Okay, so decremental conduction, more frequently the node is stimulated, slower it conducts the property, slower it conducts. This property is also prevents the rapid conduction to the ventricle in case of the rapid atrial rhythms. Okay, which is innervated by the sympathetic and parasympathetic or vagus nerves. We know that. So due to the action of the parasympathetic nervous system, there will be decreased heart rate or negative dromotropic effect, but in case of sympathetic activity, there will be increased heart rate or positive conduction velocity or positive dromotropic effect as well. So AV node basically functions for the delay from the for the delay that the stimulus that comes from the SN node and goes into the ventricle, it is being delayed by the presence of AV node. Okay, when the atria contracts before the ventricle, and it basically provides the function or provides the time for atria to contract before the ventricle and protection from excessively fast ventricular response to atrial arrhythmias. Decremental contraction are basically more frequently the node is stimulated, the slower it contracts. This property also prevents the rapid contraction to the ventricle in cases of rapid atrial arrhythmias. Okay, this is innervated by both sympathetic and parasympathetic, as we all know. The parasympathetic activity will cause decreased heart rate or negative domotropic effect, and due to the presence of the sympathetic activity, there will be increased heart rate or positive dromotropic effect as well. The AV node has two functions, as we all know: the delay of the impulse that is being received by the SA node, and the fraction of second, or basically 120 millisecond, is being offered the delay that is being caused by the AV node. Why there is the delay? Because it wants the atria to contract before the ventricle, as we already have discussed about the fact the delay that occurs due to the presence of the AV node. And there is also both AV node contracts at the same time, and there will be atria and ventricle. If both atria and ventricle contracts at the same time, there will be a catastrophe occurring into the heart. So for avoiding that specific catastrophe, we will be needing the presence of AV node, which will ultimately delay the conduction from the SA node to the AV node by 120 milliseconds, and that will allow the atria to contract first before the ventricle. Blood will not be done during the will not be the in one direction from atria to ventricle if there is no presence in atrioventricular delay, right? So there will be a massacre occurring in there. If a node is dead, it will take over, right? So it is the second pacemaker after the SA node. So if by any chance or because of any disease the SA node is not working, the AV node will, or atrioventricular node will function perfectly and cause the contraction of the heart and move the heart forward due to and continue doing its function. Okay, decremental conduction, wherever there is increased heart rate, the AV node will cause the delay and more frequently, and that node of stimulus will become slower at contracts. Okay, so if the heart moves faster than it should, the AV nodal delay will take place and it will slower the heart down and move that back into the proper speed that it should go. So if AV node is damaged, the positive chronotropic effect will come into place, and positive inotropic effect will also come into place, I think. So heart rate will increase basically when there will be no AV nodal delay presence due to any disease that causes affecting the AV node. Okay, so the if the SA node is being affected, SA node basically generates the impulse. So as if SA node is affected, there will be less heart rate, but the AV node basically delays that particular impulse that is being generated by the SA node. So when the delay will be not there, there will be increased heart rate, and we will have to notice that, and this will be very important for the SBS that will come into our exams. Okay, so moving forward, as we have all known about the sodium and potassium pumps that comes through due to the presence of them, we cause the action potential as well. But in case of heart, the action potential is a bit different. We all know that, but let's see the action potential that is present in heart, right? In case of heart, the action potential is more like this. This is basically depolarization. Then there will be this plateau potential or repolarization, and which will eventually come down like this. Okay, so this part here, this is the sodium. Okay, but along the sodium there will be some calcium here. Okay, and there will be some calcium here as well. So if we are to see this, these are the channels. There are two types of channels. There is one is long acting, or and one another is transient. So this is, there will be presence of transient calcium channel here and the slow acting calcium channel in there, and there will be potassium channels as well. So the transient calcium channel is known as the T type calcium channel, and there will be L type calcium channel or long acting or slow calcium channel, that is L type of calcium channel. Okay, so voltage gated sodium channel are basically the active sodium channels that is being affected here, that is being involved in here due to the depolarization. And when the slow calcium channel comes into action, there will be this plateau potential, and when the slow calcium channels are being closed, there will be potassium coming into the case, and there will be repolarization as well. So this is the cardiac action potential that we'll have to know for our exam. Okay, so we have already known there are two types of calcium channel, the T type calcium channel and the L type calcium channel, and the sodium channel as well. Voltage gated sodium channel is basically not active, and the slow sodium channel or funny fast sodium channel is being active, which is slow basically, and the potassium channel as well. So we have exactly known the locations of these three potential or these three voltage gated channels that is being present in the cardiac action potential. Okay, so SNOD action potential is a bit different, where there is depolarization and repolarization, and four funny current, funny sodium current is basically present. So in case of this, there will be minus 40 to shift from minus 60 to minus 40 millivolt due to the presence of funny current, plus T type transient type calcium channel. As we have already known, after the depolarization there will be presence of funny current sodium channels plus the transient type of calcium channel, and after reaching that point, there will be closure of the sodium channel or funny current sodium channel, and there will be presence of L type of calcium channel, which will ultimately cause the presence of the plateau. And when the plateau is being finished and the voltage moves from zero towards the repolarization or resting membrane potential, the voltage gated potassium channel will come into place and the repolarization will occur, and we have already seen how it works. Okay, the as a node has automaticity, we will all know that this is between the 10 functions that is being caused by the heart, the automaticity, rhythmicity, and many other functions. It does not require any impulse at all to produce or generate the stimulus. Okay, it produces an action potential from the external stimulus, which is basically phase 4 of the action potential, which possibly causes slow or funny current sodium channel to open. And after the opening of the slow or funny current sodium channel, the sodium slowly influx and causes generation of the threshold potential, which moves from minus 60 to minus 40. Once it reaches minus 40, then the potassium channel, which a transient type of calcium channel, is also opens, and there will be opening of after moving into the top, there will be opening of the L type of calcium channel, which is basically phase 0 as well. So if we are to see here again the cardiac potential diagram, yes, we'll see this. Okay, see, this is phase 4, this is phase 1, where there is presence of funny current sodium channel uh, along with the transient type of calcium channel as well. And there will be presence of first of all, the after the transient type of calcium channel is being blocked, there will be presence of L type of or slow sodium calcium channel. And when the slow calcium channel is closed, there will be presence of this potassium as well. Okay, there is presence of potassium channel, which will cause the repolarization, and there is some descriptions here as well. If you can see this, there's fast sodium channels and rapid flow of sodium into the cell, then comes the potassium, then calcium, and along with them we will know how the cardiac potential has worked. Okay, so this is the cardiac potential during the phase 3, they call. So phase 3, this is the phase 3. As you can see, this is the phase 3. Potassium out and potassium rectifier also comes into place. Okay, this is the class 4 potassium channels, and there will be sodium channel, sodium in, potassium and chloride out, and calcium in. Then also potassium out, and potassium rectifier that comes into place. So this is phase 3. Okay, the opening of the voltage gated potassium channel and repolarization, then again funny current sodium channel opens, and the cardiac potential starts again. And this is basically the generation of threshold and action potential. So this is basically the cardiac potential. Okay. Membrane potential phase 4. We have seen phase 4. Given the tissue, the specialized automaticity, the cells show spontaneity. Okay. During the spontaneity, the depolarization at rest, this is spontaneous depolarization, is referred to as pacemaker potential, which will result from the inward calcium current and primarily related to the T type of or transient type of calcium channel. Inward movement of the sodium channel or the sodium current, which is caused by the funny current sodium channel, is due to the opening of the channels that evokes the sodium mediated depolarization. That transmembrane potential or basically depolarization occurs in the phase 0. That means the depolarization upstroke of the extreme potential that is mediated by the opening of the L type of calcium channel as well. So this is basically it. So you can see this 4O1 and 2 years, you can see there are potassium and chloride going out and calcium coming in, and then there will be 3 again. So 4, 0, 1, 2, 3, and then there will be again 4. So if you go through a single sequence from the depolarization section here, so there will be 0, 1, 2, 3, and into the hyperpolarization section there will be funny current sodium, there will be 4, phase 4 as well. So this is the sequence that is present. So depolarization occurs first, then repolarization in the phase 3 due to the opening of the potassium channel that is made by the voltage potassium channel. Calcium channels gets inactivated and the repolarization phase starts and occurs. So yeah, stages and phases that we have already have discussed. The stage or phase, residual potential is basically stage 4 or phase 4. Often zero phase or depolarization phase also starts from here. Depolarization is basically phase 0, that is the initial phase or phase 1. Initial depolarization occurs during this phase, and the repolarization basically phase 3, that is by the uh, raise occurs after the basically plateau potential, or the repolarization actually occurs when the plateau potential starts. So yeah, from here on the repolarization occurs, but this is being slowed by the slow calcium channel. When the slow calcium channel stops just in here, then there is only the potassium channel, and the potassium channel causes the rapid repolarization. Okay. So this all happens into the SN node and due to the action potential occurring in there. Estimated potential for ventricular myocyte is basically minus 90. In case of phase 0, that will be mediated by the opening of the voltage gated and conduction velocity. Voltage gated sodium channel and conduction velocity that is directly related to the rate of the change in which the potential slope occurs and stimulated of B1 receptor, as we have known that B1 receptor is being present there, which creates the QRS complex of the ECG. In case of phase 1, the slight repolarization is mediated by the transient potassium current. Yes, there is presence of transient potassium current in that phase as well. Sodium channels transition to the inactivated state, and in case of phase 2, there is a plateau present, which causes the ST segment of the ECG as well. Okay, influx of potassium influx of calcium via the voltage gated L type of calcium channel occurs, and the efflux of potassium through voltage gated potassium channel occurs as well. The influx of calcium triggers the release of the calcium from the sarcoplasmic reticulum, and calcium induced calcium released, which causes the muscle contraction, right? So there is in this phase, right, in case of the plateau potential, the calcium is being moved out of the cell or moving into the cell during this phase, right? This is the plateau phase where the calcium are moving in. So when the calcium moves in, there is calcium deficit, so the sarcoplasmic reticulum has to release some calcium. So this is basically the calcium mediated calcium release. The influx of calcium triggers the release of calcium from the sarcoplasmic reticulum. So due to the deficit of calcium that occurs into the inward into the cell, and which will cause the more calcium release from the sarcoplasmic reticulum, and which is basically calcium dependent calcium release or calcium induced calcium release, which will, due to the presence of this much of calcium into the cardiac potential or cardiac cell, it will cause the contraction or muscle contraction, and that's how the contractility moves forward due to the action potential as well. As for phase 3, we have seen there is the T wave basically. So we have seen for different phases. This is basically phase 0. From the phase 0, this is phase 0 where the QRS complex basically works. Okay, so phase 0 is basically QRS, and in case of phase 1, we have seen the slight depolarization, which means the potassium current and sodium channels transition to the inactive state. In case of phase 2, there is plateau. So this is phase 2, this is plateau, which is caused by the causes in case of the ECG, that is caused the ST. This is QRS and this is T. So the ST segment is being done due to the or during the calcium influx into the cell. So during the depolarization, the QRS is already done. During the plateau potential, there is the ST phase, and during the rest of the thing, that is the basically the phase 3. During the phase 3, we have already seen this is the phase 3. The T wave will be there due to the T wave there due to the repolarization phase. The voltage-gated calcium channel gets closed, and the efflux of the potassium channel, voltage-gated potassium channel through the efflux of potassium through the voltage-gated potassium channel occurs during that phase, and due to that phase, which creates the T wave into the ECG or EKG. You can say anything you want. And phase 4 are the restoration of resting potential and due to sodium potassium ATPase, right? In case of phase 4, due to the sodium potassium ATPase, there will be restoration of the resting membrane potential. So this image is very important for us. As you can see, phase 4 is basically restoration of the resting membrane potential, which will ultimately turn into the P wave. And then there is, during the phase 0 or during the depolarization, there will be QRS complex. During the plateau potential, there will be the ST segment of the ECG, and during the repolarization, there is basically the T wave that we can see into the ECG. Okay, we have seen the different phases of the cardiac action potential, and we have also seen them correlate with the ECG waves as well. And this will be very important for our exam, right? So we have seen, or we have already studied how calcium-induced calcium channel influx occurs or calcium release occurs, and which ultimately turns to cause muscle contraction. And we will also see in depth in this slide about that. So there are two types of filaments. One is thin filament and thick filament. The thin filament is basically actin, and the thick filament is basically myosin, right? If grossly we are to say that, right? So apart from the actin, there is tropomyosin as well in case of the thin filament. When the calcium binding site is being opened and there is calcium binding to that site exactly, because calcium binds to that troponin binding site and stimulates the tropomyosin. Okay, the tropomyosin start moving, and if you can see a video that you will be able to find in YouTube or anywhere, there are very clean videos that are being indicating how that exact procedure occurs. So when the calcium gets binded to that particular receptor, calcium binding receptor, which causes which starts moving the tropomyosin, and it will expose the ends of the actin, okay, which known as the myosin binding site. So the calcium moves into the calcium binding site, which binds with the troponin binding site is called the tropomyosin, and it gets binded, and then only the tropomyosin start moving. And when the tropomyosin start moving, it exposes a site where actin can bind with the myosin, right? Okay, the tropomyosin moves forward, and it makes a place for binding with the actin for the myosin. Okay, The phosphorylated myosin will bond to the myosin binding site and the cross bridge formation. And when the cross bridge is formation, there is a head that will get attached to the that exposed sides of the actin, and ultimately the muscle contraction will occur. If we are to see about the actin myosin, myosin diagram, okay. This is the actin myosin diagram, right? As you can see here, the myosin filaments are there, and these are the actin filaments, right? So tropomyosin, when there is action of tropomyosin, and these are the heads that will get binded, okay. These heads, okay, these are the heads that will get binded to actin. These are the bits and pieces, right, that you can see. This is binded to this part of the actin, and when they get binded, only then there will be contraction, okay. And molecular biology, you can see about that there are different lines and um, things going on in here. There will be Z-dix, there will be M line, there will be thick and thin filament, there will be darker side, there will be lighter side, okay, right? So you'll have to know that in detail if you want to, but for our exams, that M line, Z band, A band. A band is basically this, which is basically the darker part. The I band is basically the lighter part. So in between the Z band, there is basically this H band as well, and there will be Z at the end of every sarcomere, right? This is the Z band, and this will present in from here to here. This is one sarcomere, okay. And these are the details. This video you can see if you can go through YouTube, right? So for us and for our exam, the binding of the actin and myosin and occurring of the occurring of the muscle contraction is very important. And you can, if you can go through this schematic diagram, you will be more than, I guess, prepared for that. Thick filament is basically myosin, which utilizes the ATP and gets phosphorylated, and that phosphorylated myosin right here, phosphorylated myosin binds with the actin as well. Actin, myosin binding site in the actin. Affinity towards the myosin binding site gets also increased when the myosin gets phosphorylated, okay. The excitation contraction coupling, okay, once the electrical activity reaches the cells, reaches to the cell's membrane, it goes inside by the cell like a finger like projection, which is the T tubules, which is also present in there. And it stimulates the receptor inside the cell. It stimulates the sarcoplasmic reticulum, which ultimately releases calcium, and the calcium will bind with the troponin, as we have already seen, troponin calcium binding site. Okay. The outer covering of the cell is basically the cell membrane. T tubules are finger-like projection or invagination of the sarcolemma. T tubules are action potential to the inner part of the muscle fiber and releases calcium from the sarcoplasmic reticulum into the cytoplasm. We have already seen. Okay, T tubules are basically present in there as well from the sarcomere. Through the T tubules, the calcium comes out. If you see here, there will be T tubules as well. If you see in a bigger picture, no worries, you will find out the T tubules, and through the T tubules, the calcium comes. The calcium dependent calcium release occurs, and that gets binded to the fiber, right? E troponin calcium binding site. That tropomyosin site calcium gets binded. We have already studied that, right? The calcium binding site into the tropomyosin stimulates the tropomyosin, which starts moving. Then it exposes the site for myosin. Myosin get phosphorylated. That phosphorylated myosin has more affinity towards the binding site, and when the into the binding site, the myosin get attached. Cross bridge formation occurs, and also muscle contraction occurs as well. Mm, Excitation contraction coupling is also, once the electrical activity reaches the extreme potential, we have already seen that efflux of sarcolemma from the sarcolemma, it will get inside the finger like projection T tubules and opening of the two channels of the calcium and stimulate the sarcoplasmic reticulum or endoplasmic reticulum. So there will be effect of calcium to the cytoplasm, okay. Myocardial contractility increases with an increase in the myocardial contractility increases with the increase in the heart rate, and the inability of the sodium potassium ATPase pump to cause that effect to maintain the adequate influx of sodium at a higher heart rate that results in accumulation of calcium into the myocytes. So when the myocardial contractility increases with increase of the heart rate, the inability to sodium potassium ATPase pump system to maintain the adequate influx of sodium at higher rate results in accumulation of calcium into the myocyte, thereby leading to the increased myocardial contraction. So whenever there is more amount of calcium coming into the myocardium, and which causes the muscle contraction, and ultimately there will be more contraction due to the presence of calcium into the cell membrane, which is the Treppe effect or Bowditch effect. Okay, so Treppe effect is important in due to the myocardial contractility increases with increased heart rate, inability of the sodium potassium ATPase pump to maintain that particular function. The heart rate results in this higher heart rate results in accumulation of calcium into the myocyte, and thereby leading to increased force of contraction or force of myocardial contractility, right? Sodium potassium ATPase pump will be unable to function due to the myocardial contractility. So when the heart moves really fast or heart contracts really fast, and the myocardial contractility will increase, and due to this increased myocardial contractility, the sodium potassium ATPase will not have enough time to function or maintain the adequate influx of sodium at higher heart rate. Okay. So as there is impaired function of the sodium potassium ADPS pump, there will be accumulation of potassium, right? As we have already seen during the cardiac potential, there is influx of calcium into the cell, right? During the plateau potential. So all this calcium will come into the cell and they get stored as the sodium potassium ADPS pump is not working properly. So, and due to this, the an accumulation of calcium into the cell, there will be leading to increased force of contraction and more myocardial contractility, and this is the Treppe effect or Bowditch effect. Okay, so heart rate increases due to the increased impulse, and due to that, the whenever there is more heart rate contractility, more contractility happens, it causes expenditure of ATP, and due to the expenditure of ATP, more and more ATP is used, causing lack of ATP. Due to the lack of ATP, inactivation of sodium potassium ATPase pump will occur, and so no sodium going out, no efflux of 3 sodium, as there will be no sodium efflux and no potassium influx. But the from the sarcoplasmic reticulum, the calcium will come out through the T tubules, and then they also get stored and they will cause the contractility, right? Uses the trepe or bond which the effect occurs, and the cardiac inotropic effect is being done. Inactivation of sodium potassium ATPase pump, increase sodium in calcium into the cell. In the cell, calcium will increase, and due to intracellular calcium increase, there will be more force of contraction and there will be more contractility, right? So that is how the Treppe or Bowditch effect works. Okay. Now, what is hypoxia? Hypoxia is basically lack of oxygen in our tissue, or anaerobic state where our cells or tissues does not get enough oxygen that it needs. Okay. In the early phases during the ischemia, there is an intracellular sodium concentration will be affected due to this, and production of lactic acid will be done due to the anaerobic respiration. Okay, sodium proton exchange pump is basically present in the cell membrane as well. So sodium entry occurs through that membrane as well. This contributes to the increased sarcoplasmic reticulum. This occurs due to the increased sarcoplasmic reticulum, and due to the increased sarcoplasmic reticulum and activity, calcium will come around as well, and due to the presence of calcium content, larger calcium transients and thereby positive inotropic effect, as we have already seen, will occur into that part of the cell. Intracellular protons strongly inhibit the sodium and sodium calcium exchange activity, and competitive binding will occur. The in exchange of sodium entry, in exchange of sodium, there will be increased concentration of intracellular sodium as well, And finally, due to the presence of sodium, and as the sodium potassium ATPase pump is not working properly, there will be intracellular calcium presence as well, which will ultimately result in increased contractility. So in early phase during the ischemia, there will be a rise in intracellular sodium concentration that is mediated by sodium proton exchange pump and the sodium channel entry as well, which contributes to the increased sarcoplasmic reticulum calcium release. And so larger contents of calcium will also get into the cell and stay in there due to the presence of this much amount of calcium into the cell, and also the intracellular sodium level as well. The contractility will ultimately increase. The calcium exchange activity will have a competitive binding with sodium, and they will ultimately get stored into the cell and cause increased contractility as well. So when the hypoxia occurs, there will be inadequate oxygen into the cell. Anaerobic respiration will take place, production of lactic acid. Due to the presence of lactic acid is the acid which will contain the proton or H plus. This toxic H plus ion will need to get out. So as this ion needs to get out, the potassium ion or proton pump basically pumps outside the proton in exchange of sodium. So sodium gets into the cell, so there will be more amount of sodium into the cell, and this sodium will ultimately cause the release of calcium in the cells. So sodium calcium ion channel cannot work due to the excess sodium in the cell, which will ultimately cause the inactivation of the sodium calcium exchange pump. So the calcium cannot also go back from the that cell as well. So there will be more intracellular calcium present in the cell, which will finally tends to presence as increased contractility as well. In case of norepinephrine, we have already seen the beta 1 receptors is being used due to the action of norepinephrine or noradrenaline, which will through ATP and cyclic AMP as the second messenger system would result in the opening of sodium potassium ATPase pump or sodium calcium ATPase pump, which will ultimately get blocked, and more calcium gets into the cell and contractility increase. This is also the same mechanism that we have already discussed. So as the opening of the sodium channel or inactivation of sodium calcium pump, this enhances the activity of voltage dependent calcium channel, and this effect being mediated by the beta adrenoceptors. The beta adrenergic stimulation stimulates an increase in the intracellular contraction of the cyclic MP, which leads to the phosphorylation of the voltage gated or voltage sensitive calcium channel in the myocardium. During the membrane depolarization, this results in influx of calcium across the sarcolemma, and due to that there will be increased contractility. As we have already discussed this, the same thing is being stated here. This basically enhances the activity of voltage dependent calcium channel, and this affects the is mediated by the beta adrenoceptor. Beta adrenoceptor or beta adrenergic stimulation results in increase of the intracellular contraction or cyclic MP, which leads to the phosphorylation of the voltage calcium channel in the myocardium during the membrane depolarization. This results in increased influx of calcium into the across the sarcolemma, and there will be more contractility as well. Noradrenaline or norepinephrine binds to the beta 1 receptor, and we have already discussed, and the adrenoceptors on the membrane and causes increased calcium entry via type of calcium channel during the action potential, and which causes the calcium release from sarcoplasmic reticulum, and that amount of calcium gets stored, and ultimately which causes the contractility of that cell or that cell membrane as well. Okay, so gap junction or desmosomes are present in there. They are also known as connections or connection. The gap junction are specialized intracellular connection which enables the action potential to be passed effectively, so that the myosin functions as a single contractile unit. So the desmosomes provide cell to cell adhesion, and these gap junctions are present, so there will be contractility presence, and this is also a specialty of the cardiac muscle as well. When the desmosomes provide cell-to-cell adhesion, facilitating the rapid spread of action potential and synchronized action of the myocardium, which in the whole heart acts as one cell, which is also known as the syncytium as well. Okay, so annulus fibrosus cordis. Annulus fibrosus cordis is basically the skeleton of the heart. So there is a fibrous ring that is present surrounding the atrioventricular junction or the atrium and ventricle. This is a physical barrier to propagation of the action potential between the atria and the ventricle, which defects the abnormalities of the epiconduction and which may result in WPW or LGP syndrome as well. These are some serious symptoms you can already know them about them, or you can already find them out in ECGs as well. There are different features which you can see in ECG, and you can diagnose a patient with. Like if you can find a delta wave in ECG, you can find or you can diagnose the WPW syndrome as well. So insulation already present so that the impulse from the SA node cannot directly reach into the ventricle. It has to go through the atrioventricular junction, which is basically in the fibrous ring as well, which is surrounded the atrioventricular junction, or AV node in other terms, which is basically a physical barrier to propagation, which ultimately causes a delay. And the delay is important for them to contract in regular fashion, or the atrium to contract first before the ventricle, which will save us from different catastrophes as well. So durations are very important in our cardiac cycle. So if we are to know about the exact duration, the PR interval is 120 to 220 milliseconds. That is basically 3 to 5 small boxes in a ECG graph or ECG paper basically. QT prolongation, we can say QT is prolonged in men when it is more than 440, in women when there is more than 460, right? So QT more than 500 is associated with increased risk of torsades. Torsades is basically uh, VT, multi-directional VT as well, multimodal VT, and torsade point is very important. And the treatment of torsade point is basically magnesium sulfate 2 milligram. 2 gram magnesium sulfate will in infuse just after we have diagnosed a patient with torsades. Okay, this is not important right now, but we are studying the intervals and we'll have to correlate with the diseases as well. That's why I have told you, right? So PR interval, the regular PR interval is 120 to 220 milliseconds. The QRS is anything less than 440 is okay, but in case of men more than 440 is more. QT is prolonged basically, and in case of female, the QT, if their QT is more than 460, that is also considered as the prolonged QT. And in any case, if the QT is more than 500, we should consider that as a risk of torsades, and we will treat the patient immediately, right? QRS is basically 0.10 to 0.12, that is the normal range. And if the QRS is basically more than 0.12, that is basically the prolonged or large QRS, and we will have to find out the cause for that as well. P is basically, in case of ECG, as we are talking, the P is basically atrial depolarization, and QRS is basically ventricular depolarization, and T is basically ventricular repolarization and ventricular depolarization. So atrial repolarization is overlapped by ventricular depolarization. Okay, ventricular atrial repolarization is overlapped by ventricular depolarization. So QRS, in QRS, as we have seen atrial depolarization, but we have not seen any atrial repolarization. But this QRS complex in total, this in there is being this ventricular depolarization is also overlapped by the atrial repolarization as well. So but for our exam purpose, we will have to know that P is atrial depolarization, QRS is ventricular depolarization, and T is basically ventricular repolarization. And in there, into the QRS, it will be overlapped by the atrial repolarization as well. And for the last topic of our class today, we will be discussing about the different portions of our chest which will hold the different chest leads for our ECG, right? So basically, we have some limb leads, we have some chest leads. If we are to divides our ECG leads as well. In between them, the V leads from V1 to V6, they are basically front leads as we can say them, and we will have to know about the positioning of these leads for the better ECG reading, or even if you are instructing an ECG to a nurse, that how should he or she should place the leads, or where he or she should place the leads. You will have to know about the exact position that where they should be placed, right? So precardial chest leads are basically V1 to V6, and we will know about their positions as well. So V1 we will be placing in fourth intercostal space at the right sternal edge. Into the right sternal edge in fourth intercostal space, we'll be placing the V1. In fourth intercostal space in the left sternal edge, we'll be placing the V2. So in the fourth intercostal space, we are immediately just in the right and left side of the sternum, we are placing V1, and V2 we are placing the V1 in the right sternal edge of the right fourth intercostal space, and we are placing the V2 in the fourth intercostal space of the left sternal edge. Okay. Okay, in the V3, we are placing in midway between the V2 and V4. We were placing the V2 in the left sternal edge in the fourth intercostal space, and in between the V2 and V4 will be placing the V3. So now we'll have to know where will we place the V4. We'll be placing the V4 in the fifth intercostal space in mid clavicular line. So as we have started from V1, V1 was on the right sternal edge of fourth intercostal space. Then we move to the V2, which we have placed on the left sternal edge on the fourth intercostal space, and now we are starting about the V4, right? V4 will be placing in the mid clavicular line in the fifth intercostal space, and in between the V2 and V4 we will be placing the V3. Moving forward about the V5 and V6, the left anterior axillary line at the same horizontal level as V4 will be placing the V5, and in the mid axillary line at the same horizontal level as V4 we'll be placing the V4, and V5 we will be placing the V6. So yeah, if we are to summarize about the limb leads, so we are placing two leads on the fourth intercostal space on the right sternal edge. Fourth intercostal space we are placing the V1. On the left sternal edge we are placing the V2. Then we'll discuss about the V4. V4 will be placing in the fifth intercostal space in the mid clavicular line, and in between the V2 and V4 will be placing the V3, and the V4, 5 and 6 will be on the same horizontal line. The V5 will be on the anterior axillary line, and V6 will be on the mid axillary line, but the horizontal plane will be same for all of them. So all of them should be discussed for the placing of the limb leads, not because of the chest leads are very important for our ECG. So yeah, all of this ECG limb leads of the or the chest leads are important for placing, and that is for our class today. And we'll be discussing the further about this class and further about basically cardiovascular physiology in the next class. If you have any questions, you can directly contact me through any medium. Thanks for attending the class. See you guys.